Good morning, everyone. Thank you so much for being here. We'll be starting in about 2 minutes. Hi, good morning, everyone. Let's get started. France, you're on.
Good morning, good afternoon, good evening. My name is France Donnet. I'm an obstetrician with a public health expertise and a career with UNICEF, UNFPA, and the Gates Foundation, and I'm now a consultant on global women's health. On behalf of the Women Deliver team, it's my pleasure to welcome you to the first webinar on diabetes in pregnancy, an epidemic holding back progress. Today's session will focus on the evidence behind the need to address hypoglycemia and diabetes in pregnancy. We are going to learn from 4 distinguished panelists. They will talk about these conditions, their prevalence, and their impact on the health of mothers and newborns. We will hear the 4 presentations back to back, and they are 10 minutes each, and then we will open the floor for questions and comments. The first speaker is Dr. Anna Langer. Dr. Anna Langer is with the Harvard T.H. Chan School of Public Health. She joined the school in 2010, and she's a professor of practice of public health and coordinator of the Dean Special Initiative on Women and Health. Anna Langer is a physician with a specialty in pediatrics and neonatology and a reproductive health expert. She's from Argentina. She published extensively on maternal mortality, on psychosocial support during pregnancy, labor, delivery, and the postpartum period, on quality of maternal health care, unsafe abortion, emergency contraception, and the introduction of evidence-based practices in maternal health services. She is the director of the Maternal Health Task Force, which works towards the improvement of maternal health globally through evidence on maternal health, promotion of effective policies and programs, and the education of emerging leaders in the field. In 2015, in addition to that, Dr. Langer published the comprehensive report Women and Health, a Key to Sustainable Development in the Lancet. The paper analyzes women's health along the life cycle and its connection with social determinants of health and global transitions, and provide evidence to the critical role of women in terms of their own health and their family's health. Dr. Langer was president and CEO of Engender Health from 2005 to 2010, and prior to that, she was the Population Council Regional Director for Latin America and the Caribbean. Dr. Lange will give an overview of the gains made in maternal health in the last decades and address the rising need of indirect causes of maternal morbidity and mortality, and particularly diabetes in pregnancy. Dr. Lange, you have the floor.
Friends, this is very, very generous of you, and also thank you to the organizers from Women Deliver for inviting me to participate in this important webinar. I am now trying to share my screen. Can you please confirm that you can see it well?
Yeah,
Hello?
Anna, we can see it perfectly.
Thank you so much. And welcome everyone, good morning, good evening to those of you participating from different time zones. Well, this seminar focuses on a critical topic, the urgent need to integrate chronic non-communicable diseases and diabetes in particular with maternal health care. In global health, too often we work in silos and specialize in a particular disease or age group. But in reality, individuals, women in this case, experience a complex array of conditions that often affect them simultaneously and or through their life cycle. Narrow approaches are not the right answer to comprehensive women's health needs. That's why this webinar is so fundamental, particularly at this time. I will now share with you some key data and concepts about maternal health in the context of women's health, and we'll finish with some very general recommendations to move a comprehensive maternal health agenda forward. I will start with a brief overview of progress made in maternal health in the period covered by the Millennium Development Goals in 1990 to 2015, using the most common metric, maternal mortality ratio, globally and by region. Thanks to the sustained commitment and hard work of global and national maternal health communities, progress was achieved in the world. The world is represented by the gray line, more or less in the middle of these lines on this graph. Globally, on average, maternal mortality declined by 44%. But progress has been patchy over regions, and the 75 reduction that MDG 5, which was the MDG for maternal health, had set as a goal, was not achieved in most settings. Sub-Saharan Africa, for instance, which is the line on the top, had the shortest decline, but still the highest level of maternal mortality. Southeast Asia, which is the second line from the top, also had an important decline and is now very close to the global average, but still far from where it should have been by now. As we can see, maternal health is in transition in terms of levels of maternal mortality, and it is also changing in terms of the conditions that lead to maternal morbidity and death. The obstetric transition conceptual framework helps understand these changes. This is a model developed by Sousa and colleagues at the World Health Organization. The obstetric transition framework describes the evolution of maternal health in countries around the world in terms of levels and causes of maternal mortality and predominant models of obstetric care. In the blue box, you can see that countries have evolved over time from high to lower maternal mortality. And also in the yellow box underneath, from direct or obstetric causes of maternal death, such as hemorrhage, pregnancy-induced hypertension and eclampsia, infection, complications of abortion and obstructed labor, to indirect causes, or in other words, conditions that are sometimes pre-existing or happen during pregnancy but are not directly related to it but are aggravated by the pregnancy, among which non-communicable diseases represent a significant proportion. Finally, the green box on the right side of the screen shows that countries evolve over time from considering pregnancy and delivery a natural event towards an institutionalized approach and sometimes an over-medicalized model of maternal health care. For today's discussion, the most relevant point is the transition of causes of maternal morbidity and mortality in the context of the important epidemiological changes that women's health is going through globally, but most importantly in low and middle income countries as well. In this graph, we see causes of death among women of all ages globally. Green represents nutritional, infectious, and reproductive conditions, and orange represents non-communicable diseases. Focusing on the latter, non-communicable diseases, we can see that they now represent a large proportion of causes of death for women 20 to 44 years of age and older. Let me emphasize again but in fact, as you can see, they also affect children and younger women, the bars at the bottom of the graph. Let me emphasize again that this is global. The data are global. But if we disaggregated it by region or country, the pattern would still be very similar. Changes in lifestyle and diet and the overweight and obesity epidemic in low and middle income countries, particularly in urban settings, contribute to the emerging epidemic of non-communicable diseases and diabetes in particular. And that is not surprising that NCDs play such an important role throughout the life cycle. Because in reality, women's health is a continuum through the life course. Each stage of the life course influences the health and well-being at subsequent stages and the next generations as well. Positive and negative effects on health accumulate over time, such as the care women receive or the lack thereof, the risk or protective factors they are exposed to, and of course the health conditions they experience at each stage of life. Let me give you some quick examples. Gestational diabetes, in the blue box, increases the risk of type 2 diabetes by 60%, especially in the first 5 years after delivery. Peripartum depression, the yellow box at the bottom, increases the risk of chronic depression by 30 to 50% and may be linked to a pre-existing depression and anxiety. The green box on the right, pregnancy-induced hypertension, increases the risk of chronic hypertension, especially if women have recurrent preeclampsia and premature deliveries. While these connections have been demonstrated through clinical research, they are not apparent in the minds of policymakers, practitioners, donors, and women themselves. We have a full agenda to tackle in front of us. So what are the most important priorities for maternal and women's health in the context of this complex epidemiologic and health systems transition? First, ensure quality care for emerging conditions that affect maternal and newborn health, like diabetes. Second, in order to do so, health systems will need to be strengthened by improving infrastructure and the health workforce so systems are ready to tackle both old and new challenges. In other words, direct and indirect causes of maternal morbidity and mortality. Third, instead of creating parallel programs and services, we should build on platforms that already exist and add to them the resources that are needed to enable them to offer quality care to women's comprehensive health needs throughout the life course. Finally, in order to accelerate towards integration of diabetes and other NCDs with more traditional maternal health care, it is essential to generate evidence on how to do it in an effective, feasible, and acceptable way, and how to translate evidence into programs, advocacy, and accountability. If we as global and national maternal health communities fail to effectively address the challenges of NCDs and diabetes in particular, the progress made in the last years will plateau and maybe even reverse. Breaking silos, thinking innovatively, and evaluating our efforts to learn both from successes and failures will allow us to better serve women, children, and families around the world. Thank you very much.
Thank you, Dr. Lange. Thank you, Dr. Lange. We will now hear from Dr. Gorka Roglic, who is with WHO. Dr. Roglic has received training as a physician and epidemiologist at the University of Zagreb, Croatia, and the London School of Hygiene and Tropical Medicine in London. Before joining WHO, Dr. Roglic worked as a clinician and epidemiologist at the University Clinic for Diabetes, Endocrinology, and Metabolic Diseases in Zagreb. Dr. Roglic joined WHO in 1999, and he is the medical officer responsible for diabetes management and individual level prevention within the Department of Management of Non-Communicable Diseases, Disability, Violence, and Injury Prevention based in Geneva. She provides technical advice to member states on public health aspects of diabetes and is responsible for the development and update of WHO norms and standards related to diabetes diagnostic and management. Dr. Roglic will help us understand the several conditions under the label of diabetes in pregnancy, its epidemiology and implications on women and newborns' health. Dr. Roglic, please.
Many thanks for the introduction, Dr. Donnet, and greetings to all the participants and the host, Women Deliver, who has given me this opportunity to present a few slides on the burden of diabetes and to touch upon diabetes in pregnancy and gestational diabetes. As I'm sure all of the participants are aware, diabetes is a serious and chronic disease, and there is hardly an organ system that is not affected by diabetes. It is among the leading causes of blindness, of kidney failure, of cardiovascular events and mortality, of lower limb amputation, and has long-term consequences and is often a condition that incurs catastrophic expenditures in people that have it. It's characterized by elevated blood glucose, and that's what its definition is derived from. And it occurs either roughly when the pancreas does not produce insulin at all or very little, which is type 1, or the body cannot effectively use the insulin that it produces. The WHO classifies the main types of diabetes as type 1, which is a minor proportion of all diabetes, a relatively rare disease, type 2, which is the most common, and then we have gestational diabetes, which WHO classifies as a milder hyperglycemia in pregnancy. In many research papers and in everyday work, clinicians and researchers use different definitions of gestational diabetes, and very often the definition is hyperglycemia of varying intensity during first recognized in pregnancy. So in fact, some of these definitions include diabetes per se. In the WHO definition, it is classified as a milder hyperglycemia in pregnancy. The report that we issued last year on World Health Day that was dedicated to diabetes showed that the current burden of global burden of diabetes is over 400 million people, and that is almost 4 times the number that there lived in the world with diabetes some 35 years ago. Of course, some of that burden is attributable to the aging of the population, because age is one of the stronger risk factors for diabetes. However, if we age adjust the diabetes prevalence, we still see an almost doubling of the prevalence in the past 35 years. And looking at trends, and these trends are by country income as classified by the World Bank, it is interesting to note that 35 years ago, the highest prevalence of diabetes was in high-income countries, and the lowest prevalence was in low-income countries. And in the intervening decades, the prevalence in high-income countries has risen least, and now it is the lowest in the world, lower than in low-income countries, and the highest prevalence is now in upper middle-income countries. An example of several countries of the prevalence of diabetes in women roughly of childbearing age. We do not have data on diabetes below the age of 20. We see a pattern that reflects regional characteristics. We see that in all of these countries, and it's the case with all the regions, that the prevalence increases with age. But in some regions, some countries, the increase is more dramatic and more steep. So historically, prevalence increased fastest in the Middle Eastern region, and then the next fastest increase in prevalence was in fact in sub-Saharan Africa, which still does not have a very high prevalence of diabetes, but the prevalence has more than doubled in the past 35 years. This pattern of increase with age is seen in all countries. What about the prevalence of gestational diabetes? We are on much shakier ground regarding that information. The reports in the literature have a very wide range between 1% and even up to 25%, but it does largely depend on diagnostic criteria because they are not all equally strict, and it does depend on ethnicity of the population. So what are the major risk factors for type 2 diabetes? And many of them are also risk factors for gestational diabetes. It is age, diabetes in first-degree relatives, ethnicity, and history of gestational diabetes. These factors are unmodifiable. Increased risk of diabetes is found in Southeast Asians, especially at lower body mass index than that in Caucasian populations, but then also increased risk in Afro-Caribbeans and Hispanic whites and Native American populations. The modifiable risk factors would be obesity, physical inactivity, and smoking. And for gestational diabetes, Asian women are at higher risk of gestational diabetes than other ethnicities at similar body mass index values. The trends in overweight and obesity, if we look at them, the prevalence of obesity has nearly doubled between 1980 and 2014, and currently about 40% of men and 40% of women are overweight, and 11% of men, 15% of women worldwide can be considered obese. So that is a huge proportion of the total population that has a body weight or body mass index that puts them at higher risk of diabetes, but other non-communicable chronic diseases as well, such as cardiovascular disease and even some cancers. What has been noted in some studies in populations that have been examined subsequently with the same methodology is that diabetes seems to be becoming more frequent at younger age groups, which has, of course, implications for the coincidence of diabetes and pregnancy. In 2001, in a study in southern India, about 25% of all people with diabetes were 20 to 44 years old, and only a few years later, more than 1/3 of all people with diabetes were in this relatively young age group. There are similar data from China that also show that prevalence has increased in younger age groups. Another disturbing element is the high proportion of diabetes that is not diagnosed and consequently not treated. This is a study done by the International Diabetes Federation and published in their World Atlas, and their estimates are that, for example, in Africa, about 70% of all people who have diabetes are not diagnosed. And even if we look at Europe or North America, where most of the countries are high-income countries, at least a third of people with diabetes are undiagnosed. This is also partly because type 2 diabetes does often not have any symptoms. The International Diabetes Federation attempted this very interesting estimation. They were courageous enough to go through this analysis to see how many pregnancies, what proportion of pregnancies is affected by some degree of hyperglycemia. And this is their subdivision of regions. There were not studies from every single one of these regions, so there have been some extrapolations. So with a grain of salt, we can say that the prevalence of some disorder of glucose metabolism is quite high in all the regions. It is exceptionally high in Southeast Asia. That might also be in part explained by the criteria that have been used. And then the authors attempted to quantify the proportion that is probably due to diabetes itself, which means the rest would be gestational diabetes. And we have interesting data like North America and Caribbean. About 1/4 of hyperglycemia in pregnancy would actually be diabetes, while in Southeast Asia, about 10% of all hyperglycemia in pregnancy is diabetes. The remainder would be gestational diabetes. And if we look at the relationship between hyperglycemia in pregnancy and most frequent adverse pregnancy outcomes, short-term and long-term, there is no doubt that diabetes type 1 and type 2 increases the risk of many adverse outcomes, such as congenital anomalies, miscarriages and stillbirth. Perinatal and maternal mortality are increased in women with diabetes. Neonatal macrosomia, or large for gestational age babies, also. Future diabetes in offspring, the risk is also increased in women with diabetes. Hypertensive disorders of pregnancy, preeclampsia, eclampsia, are also increased in women with diabetes. For non-diabetic hyperglycemia, or gestational diabetes by the WHO definition, we don't really have information on these adverse events. We have information on neonatal macrosomia and on hypertensive disorders of pregnancy, and in fact, immediate pregnancy outcomes where the diagnostic criteria that were used for, well, where the outcomes that were used for establishing these diagnostic criteria, which WHO has the same as the International Association of Diabetes in Pregnancy study groups. So while many papers will say gestational diabetes predicts future diabetes in the mother, it is not quite really astonishing that glucose predicts future glucose, but we do not really have information whether this relationship actually holds for the current WHO criteria, because they have been established relatively recently and there haven't been many studies of follow-up to establish the relationship. And then, of course, there are many still questions that need to be answered about the treatment of hyperglycemia in pregnancy and how well does it prevent common adverse pregnancy outcomes. So there is no doubt that treating type 1 and type 2 diabetes will reduce major adverse pregnancy outcomes. The problem, for example, with congenital anomalies is that type 2 diabetes is frequently undiagnosed, and by the time that pregnancy is established, the major period of organogenesis has already taken place. It might be too late to prevent congenital anomalies and some miscarriages. That is why preconceptional care is advocated. For non-diabetic hyperglycemia, we do not really know whether treatment prevents all these outcomes, except that we know that it prevents neonatal macrosomia and it prevents hypertensive disorders of pregnancy. Does it prevent future diabetes in the mother? We don't know, and we do not have a very good or any idea of how, if everything is well managed and controlled and all women are identified and treated, what effect that would have on maternal mortality, perinatal mortality, and the future burden of diabetes in the mother and the offspring. So there is a lot of questions for the researchers to answer. Thank you.
Thank you so much, Dr. Robisch, for a very informative presentation. And next, we will hear from Dr. Anil Kapoor, who is the chairman of the World Diabetes Foundation based in Denmark. He received his MD Internal Medicine in 1981 from the Maharaja Sayajirao University of Baroda, India. He is the Vice President of the South Asia Initiative on Diabetes in Pregnancy. He is a member of the FIGO's Working Group on Hyperglycemia in Pregnancy. He is a former Managing Director at Novo Nordisk India and a former Chairman and Managing Trustee at Novo Nordisk Education Foundation. He has over 35 years experience in clinical medicine, clinical research, business, diabetes, advocacy, and public health. He has published more than 90 papers and 10 monographs on diabetes for medical professionals and books for lay people, and delivered many lectures on various aspects of diabetes. He organized scientific and advocacy meetings, including the highly successful regional diabetes summits in Vietnam, Kenya, Brazil, India, China, and Saudi Arabia, and he is the recipient of the Prince Hendrik Medal of Honor from Denmark. Dr. Kapoor will present the evidence based around diabetes in pregnancy and introduce us to the FIGO guidelines. Dr. Kapoor, you have the floor.
Thank you, Franz. Thank you for that kind introduction. Good day to everyone who's listening. We heard from Dr. Goika Roglic about the aspects about the epidemiology of gestational diabetes and diabetes in general. I would take you through what the FIGO, which is one of the largest obstetrics and gynecology professional organization, has been doing in terms of raising awareness and advocacy, and also starting to fund research around that area. So if you look at hyperglycemia in pregnancy, the issue is, why is it relevant? So one of the most important aspects is that hyperglycemia is one of the most common medical conditions that women encounter during pregnancy. And as we heard from Dr. Roglic, that the rates of diabetes in the younger population are going down. At the same time, we know that the age at conception is going up, and therefore it is very likely that women will meet diabetes during their reproductive age. And therefore, both diabetes and gestational diabetes are on the increase. The International Diabetes Federation, which Dr. Roglic was referring to, has estimated that about 1 in 6 or 1 in 7 live births occur to women with some form of hyperglycemia, and 84% of which is roughly because of gestational diabetes. Now, it's also important to understand that it is relevant to test and identify women who might have hyperglycemia during pregnancy, because it helps us identify women who are at high risk of poor pregnancy outcomes. It helps identify women who are probably at the highest risk of future diabetes and cardiovascular disease, and also the offspring of these women who are at very high risk of obesity and perhaps type 2 diabetes if preventive action is not taken. And therefore, it provides the opportunity to bridge the maternal newborn child health agenda and the NCD agenda together. Hyperglycemia in pregnancy is unfortunately grossly neglected. And in most parts of the low and low middle and upper middle income countries, which account for 85% of the global deliveries, 90% of the maternal and perinatal deaths and poor pregnancy outcome, and 80% of the global burden of diabetes, hyperglycemia in pregnancy, as we heard, contributes to increased risk of obstructed labor, preeclampsia, postpartum hemorrhage, preterm delivery, neonatal asphyxia, birth injury, and perhaps future diabetes and cardiovascular disease in both the mother and offspring. Unfortunately, in these countries, majority of women are not tested for diabetes during pregnancy, and that is an important issue. So if we assume that there are 127 to 130 million pregnancies around the year, every year, about 21 million of these might be affected by hyperglycemia in pregnancy, based on the estimates from the International Diabetes Federation. But unfortunately, only about 3 to 4 million of them actually get detected, and if they get detected, they are treated. The important part is that when we detect hyperglycemia in pregnancy, which is because of gestational diabetes, you don't need very complex treatment. It is about advising good lifestyle and taking care of the health. The most important part is that although hyperglycemia in pregnancy identifies women at much higher risk of future diabetes, the great problem is that these women are not followed after delivery, and they are not given preventive advice, and no attempt is made to address health promotion in these women. And therefore, this is a very important aspect which is being missed. FIGO, as I mentioned, is one of the largest organizations of obstetricians and gynecologists in the world, and they instituted a program wherein they set up an expert group to look at this issue, and with the remit that they would produce a document which would not just be guideline, but also will articulate a vision and call to action, and that it will provide options according to resource settings in different parts of the world and will identify key points of intervention. The expert group was formed in December 2013 and submitted a document which was then published in the International Journal of Obstetrics and Gynecology in October 2015, and subsequently a lot of other activities have taken place. So what was in this document? So one of the most important aspects, and this is what we heard from the first speaker, that we need to move away from silos and that we need to link issues. And therefore, one of the key points that was that given the link between hyperglycemia and pregnancy and poor pregnancy outcomes and future risk of diabetes in both mother and offspring, a focus on prevention, screening, early diagnosis, and managing hyperglycemia in pregnancy is needed globally. And that FIGO calls upon that there should be greater attention and focus on the links between maternal health and non-communicable diseases in the Sustainable Development Goals. FIGO also recommends universal testing of all pregnant women for hyperglycemia during pregnancy using a one-step procedure. It's very important to realize, and this was something that Dr. Roglic was mentioning, that a lot of women and a lot of people remain undiagnosed with diabetes. But in case of women, pregnancy is one point where they would seek medical help, and therefore we have an opportunity of educating them and identifying women who might be at risk of future diabetes and providing them with preventive care. So why testing during pregnancy? Because maternal and newborn outcomes depend on maternal glycemic control, and testing is the only route to diagnose gestational diabetes or hyperglycemia in pregnancy. And testing women only with risk factors actually has been shown that we will miss half the number of women who might be at risk of gestational diabetes would be missed if we only use the risk-based screening. The FIGO guidelines has adopted the WHO criteria for diabetes mellitus in pregnancy, and also the WHO 2013 and the International Association for Diabetes in Pregnancy Study Groups criteria of 2010 for diagnosis of gestational diabetes. But realizing that it would not be possible because of resource constraints in many countries around the world, other strategies that are currently in use in different countries were also considered to be equally acceptable. And one example of this is the practice that is being used in India, which is part of the national guideline for hyperglycemia in pregnancy, wherein a different approach is used. And basically, the FIGO guidelines are offering opportunities for every country to implement policies around this using appropriate finances and based on their human resources and infrastructure. The FIGO guidelines also provide standards for lab testing. I will not go through this, but basically saying that in case it is not possible to have a laboratory-based testing for plasma glucose, a glucometer, handheld glucometer, which is plasma calibrated, could also be used as a point of care diagnostics. It is describing the care for women with gestational diabetes, recognizing that nutrition counseling and physical activity are the primary tools in managing women with gestational diabetes, and almost 86% of women with hyperglycemia in pregnancy have gestational diabetes. FIGO is recommending that women with gestational diabetes receive practical nutrition education and counseling that empowers them to choose the right quality and quantity of food and physical activity, and that women with GDM must be repeatedly advised to continue the same healthy eating habits after delivery to reduce the future risk of type 2 diabetes. The FIGO guidelines are also talking about pharmacological management, and for the first time are actually indicating that in places where it may not be possible to use insulin, use of certain oral drugs such as metformin and glyburide may be appropriate. It is also recommending and promoting preconception and interpregnancy care. This is something we heard earlier. Basically, we need to increase the acceptance and access to preconception services and a universal preconception screening for malnutrition, anemia, overweight, obesity, hypertension, diabetes, and thyroid dysfunction. All of these factors during pregnancy can actually lead to fetal programming, which might increase the future risk of many of the non-communicable diseases. And therefore, it makes sense that we offer these services to women as part of the preconception service care. The FIGO guideline is laying a lot of stress on postpartum care because this is something that is often missed out. Women get diagnosed, are treated, but after delivery, these women are no longer diabetic, they are no longer pregnant, and so often the thing is, are they lost to the health system? The issue is, no, they are not. They often come to the health system with a baby, and can we do activities that can link the vaccination program of the child with postpartum care of women, and therefore this would provide opportunities for women to be advised on the issue of weight loss, on breastfeeding, on why it is important for them to eat healthy, why it is important for them to lose weight after pregnancy and to continue exercise, and sensitizing them to the fact that both they and their baby might be at future risk. Pregnancy is an immensely teachable moment, and educating women around this can actually not only help themselves with their health, but might actually be a huge opportunity of changing the behavior of the whole family. And lastly, to say that from my perspective, actually pregnancy is a huge window of opportunity for testing women during pregnancy for diabetes. It opens a window of opportunity to provide maternal care services to prevent pregnancy complications and save mothers and newborns from the immediate complications that arise because of hyperglycemia, and also help identify women and children at the highest future risk of diabetes, obesity, and cardiovascular disease, and thereby offer them early preventive care. We do not know whether treating gestational diabetes will prevent type 2 diabetes in the mother or in the offspring, but we definitely do know that women who have had gestational diabetes, when they are provided preventive care after delivery, we actually can delay the onset of type 2 diabetes and can actually reduce the risk of them getting type 2 diabetes. We also know that if we can reduce obesity level in these babies that are born to mothers with gestational diabetes, that we might be able to reduce the risk of getting type 2 diabetes and cardiovascular disease early on. And therefore, we need to address this as a more comprehensive program, as a life course approach, and not just merely focusing on just the pregnancy alone. Pregnancy is just a means to get to that life cycle approach. Thank you very much.
Thank you, Dr. Kapoor. Thank you, Dr. Kapoor, for this excellent presentation highlighting pregnancy as a window of opportunity for women and their families. So next and finally, we will hear from Dr. Emma Divakar, and we hope that she will be able to connect from Mangaluru. Dr. Divakar is a senior consultant and medical director of Divakar Specialty Hospital in Bengaluru, India. She is past president of FOXI, which is the National Professional Organization of OBGYNs in India. She is the Indian ambassador to FIGO, the International Federation of Gynecology and Obstetrics. She is a member of the Technical Advisory Group to the Ministry of Health and Family Welfare with the Government of India. She is the National Coordinator of a Quality of Care Initiative supported by Merck MSD for Mothers in India. She received the FIGO Award in 2015, and Dr. Divakar is a very active advocate for delivering quality healthcare across India and her special field of interest is care for high-risk pregnancy and diabetes in pregnancy. She will speak to the challenges faced by developing countries in addressing the condition and about the rolling out of guidelines in India. Dr. Divakar, can you join us?
Namaste. I bring greetings from 1.2 billion Indians and 35 million type 2 diabetic women in our own country, with 5 million gestational diabetes that we document every single year. There are variants of gestational diabetes in the Indian women, but the India story today is of all pregnant women for GDM is not done routinely at the health facility as a part of the package for essential antenatal care, sporadically in various district hospitals, medical colleges, or in states as per the direction of individual clinicians. Well, we want to now take that story so that every woman in the reproductive age or even before that, and even if child knows what the importance of the high blood sugar in pregnancy is likely to be impacting the present and the future generation. Next. In the Indian context, we are all aware that testing is essential for all pregnant women because Indian ethnicity predisposes them an 11-fold increased risk of developing glucose intolerance compared to the others around the world. So it is mandatory that we must offer the test to all pregnant women in India. So when you come to the story of numbers, it is 30 million pregnant women per year that need to take this test once at booking and once when they reach 20 to 22 weeks of pregnancy. Well, the recommended test as of now accepted by the DIPSI, by the Government of India, by FOXI, the national professional body, and now by the broad umbrella of FIGO, our international association. We just offer the women a one-step test, irrespective of when she has had her last meal. Give her the 75 grams of glucose and draw one single blood sample 2 hours later. We consider this as a simple, economical, feasible test because you can just imagine if you do the two-step screening test, you tell the women who are screened positive, okay, you have to report back in 3 to 5 days' time. Report at 7 a.m. Come to our center in the fasting state. We will draw your sample, and then we will give you 100 grams of glucose. We'll draw 4 more samples, and this doesn't go well with the women in India because they say, how do I manage to reach the center from 200 miles, that too in a fasting state when I'm pregnant, and 4 blood samples, one hourly, and that is a clear no-no. So both the clinicians and the women at large, this methodology was not feasible, so we had to innovate out of the necessity for access and the feasibility and logistics of the testing, and now it has scientifically been proved that a simple, economical, single-step test is the way forward for low-income countries, not only India, but the whole of South Asia and also Africa. The challenge just begins after the testing is done. As we commonly say, ignorance is bliss. If you don't test the women, you do not know their sugar status, and you do not recognize that she has diabetes or hyperglycemia. But once everybody starts doing the test, even at a ballpark of 10 to 12% prevalence, we will have millions, 3 to 5 million, those who are tested as positive, and they need the care. So we need an entire cadre of counselors because the specialists or the clinicians have to deal with such a sheer overload of the volume that it may not be possible for them to explain what next. So to inform her about how the gestational diabetes affects herself and her baby in pregnancy and even beyond that, and she needs to understand that she needs to take care of herself and the baby. She belongs to a special subset of antenatal women who need to come back and forth and take the necessary advices and follow them meticulously to get the best outcomes. We inform her why this pregnancy is different from the others and why she needs extra care. And the challenging part is to instruct her and keep her motivated to maintain a diet and a physical exercise and the sugar control back and forth throughout her pregnancy. Next. The cuisine in India, if you can imagine, is quite different from every community and every state. Every few miles, you find something that is staple to that community which the others don't eat. So broadly, if the clinicians and the caregivers who are now trained into giving them practical diet advice which they can understand and to relate to what in their context they will be able to adapt, that is the key challenge. So we explain to them the concept where one serving of fruit, one serving of a dairy product, one serving of cereals, a little bit of vegetables and proteins, and a handful of rice. So that is how, in a simple way, we have to explain and keep her to stick to a pattern of the diet in pregnancy and change her lifestyle even beyond. Next. When we say about the exercises, there are some of these which our women just cannot relate to. In their usual lifestyle, they may have some physical activity like sweeping and swabbing and washing clothes and fetching water, etc., which itself doubles up as a physical exercise, but to make them realize that it is important and to tell them in the manner that they could adopt it. Now, yoga, the whole of India and internationally, that is one form of exercise that they can relate to. So walking and yoga is our vision for the future, where we will be able to make them follow some pattern of exercise to keep the sugars under control. Next. The FIGO guidelines, which Dr. Anil Kapoor just explained, we had to brainstorm a lot to come to the understanding that every country needs to work its way around depending on the country context, depending on the feasibility, logistics, resources, etc. And it is now adopted in the FIGO guidelines for low-income countries, especially India, South Asia, and Africa, as I mentioned before, that it needs the testing which can actually be practical and pragmatic in our context. As Anil already mentioned, the laboratory tests will also need to be modified because we cannot send her to a faraway lab for the venous sample. We need to do it integrated into her routine antenatal care, whereby just the use of the glucometer, you get instant results and you'll be able to guide the patient then and there. So those are the kind of practical, logistical issues that we have to deal with back home in our own country. So FIGO has very well recognized that there are restraints in the resources, in the infrastructure, and we may not today have the high quality evidence, but we work with the mantra that if we cannot do the best, at least we have to do the good, and the best should not come in the way of good. If there is some alternative care that we can offer, it is better than very poor care or no care at all. So that is the philosophy with which the care is being instituted. That's the India story. And when it's time to decide what are all the factors that we take in consideration for a short-term decision, whether her glycemic control has been proper, whether she's on diet and exercise alone, or she is on oral medication or insulin, how large is the baby, how reassuring are the surveillance tests, and all of these with the anticipated problems of shoulder dystocia, overdistension of the uterus, and the postpartum hemorrhage, which add to the peril of the handling obstetrician or the frontline healthcare provider. So all of these needs to be integrated into a very strong capacity building, both from the supply side and the demand side. All the healthcare providers and the public at large needs to be sensitized into the magnitude of the problem, the possibility of taking certain steps to prevent the very onset of the complications, the offer of the universal testing. There should be a demand from the women themselves that why they have not been offered the test, and of course the healthcare providers have to give them the test, early detection to institute proper care and follow-up. As Dr. Anil said, the long-term follow-up with every mother and every child who has been tested to have high blood sugar in their pregnancy, that is the next story of the challenge, which will be perhaps presenting to you in our next webinar, because once they are lost to follow-up, it's very difficult to get them back into the infrastructure of healthcare for seeking preventive care. So we need to change the behavior, we need to change the mindset both of the provider and the healthcare seekers, and initiatives such as GDM Awareness Day, celebrated on the 10th of March on a campaign mode to sensitize the entire population and the policymakers towards this important issue, is something that we have embarked since the last year, and the determination to make a difference, to tap and map every single hyperglycemia in pregnancy or the diabetes in pregnancy before, during pregnancy, and beyond pregnancy is our mission, and we are well on our way with the synergies from all the stakeholders marching ahead to see to it that we present to you a better scenario. With this, we bring
So thank you very much, Dr. Divakar, for this passionate presentation. Time is up, unfortunately. We have several questions. I will just read them aloud, and they will have to be addressed offline. But one is, do you think the increasing burden of diabetes and hyperglycemia in pregnancy is contributing to the growing C-section rates in middle and high-income countries? So that's for reflection from our panelists. And to Dr. Roglic, what is the most immediate step the WHO could take to scale up addressing diabetes in pregnancy? So I don't think we have time to address those questions, but this is the first event of a series of 3 events and of a longer conversation about the issue. And we thank you for attending. And the next webinar will take place on May 12th at 9:30 a.m. Eastern Standard Times, and will address strategies and practices implemented across various geographical contexts. So thank you very much, everybody. Thank you to our panelists. Thank you to the attendees, and see you next time to the next webinar. Thank you and goodbye.
Thank you so much, France, and thank you so much to all of the panelists. And if you have questions or you submitted questions that we weren't able to address during the panel, please do feel free to email us at Women Deliver, and we can send you the responses via email. I'll send out my contact after the panel. Thanks again, everybody, and happy Friday and happy weekend.